काय होतं last time आपण? Okay, some of the antibiotics, right? So let's continue with some of the other special antibiotics. Antibacterial drugs rather. We will finish the antibacterial drugs today and then we can take this. Broad spectrum पण देते right? What was the indication of broad spectrum antibiotics? What was the indication of broad spectrum? Rare infections, mixed infections, and rare, mixed as well as UTI, RTI, reproductive tract infections, PID, pimples. These are the common indications for broad spectrum antibiotics. Now, we have certain infections which require special antibiotics. Like for example, we have tuberculosis. Tuberculosis. Leprosy. Anti-tubercular drugs, anti-leprotic drugs. These are special drugs. Why special drugs? Because the infections which are produced are major health problem today, and because of that we require special drugs for this. All of us know that tuberculosis occurs because of mycobacterium. What are the types of tuberculosis? Any idea? Types and family? Pulmonary TB and extrapulmonary TB. Next, for a detail में जाएगा. What is pulmonary TB? It is the tuberculosis of 90% patient going to find out is it pulmonary. 90% patient of tuberculosis are, but tuberculosis also affects most of the other organs. Like for example, most common is bone tuberculosis. You must have heard about. Brain, TB meningitis, organ ka tuberculosis. Then also have GI tract. Then also have reproductive tract. Also have all living tissues are affected by tuberculosis. But 90% patients going to find out is a pulmonary TB or lungs tuberculosis. Now, how exactly the organism spread? All of us know organism spreads through a droplet infection. What is that? Organism spreads through a bacilli which are cuffed out. And somebody inhales those, and because of that it is spreading rapidly, because Indians still think that spitting on the road is their birthright. Not even spitting. In fact, the recent survey says that not even coughing, but even sneezing, even talking, or even through breath also, for severe cases, the bacilli are exit. Not even through only coughing. In fact, through sneezing, it is about 1,000 times more bacilli comes out of the sneezing rather than coughing. So because of that, and the problem is the bacilli which is come outside or bacilli which are there in the atmosphere remains alive for more than 1 month. Sometimes limiting that bacillus comes out of the body and it will be killed. Bacilli will die, but bacilli will not die. In fact, somebody has spat on the road, the sputum dries, and then after the sputum dries, the bacilli are thrown in the air. Till that, the bacilli are in the sputum. And when you inhale those, and in fact, overcrowding in India, and to be more precise in Mumbai, to be more precise in slum population, and because that TB is still a major health problem in Mumbai. In fact, you are traveling in the local trains, you are handling the most dirty thing in this world is that train ka handle and your mobile phones. The recent survey, mobile phone has have you ever washed your mobile phones? Accidentally you must have washed. But you never washed. You are having vada pav here and you are handling mobile phone, right? The vada pav, the oil remains on that. The culture medium, again bacteria. Never wash your mobile phones. If you wash your mobile phones, there will be a last mobile phone. Which is mixed on it, waterproof ones. So because of that, it is spreading very rapidly. And because of that, on the top of that, we require a very long course, all of us know, minimum for 6 months, right? And nobody consumes or nobody takes this drug for more than about 6 months. They discontinue the drugs, and that is what is becoming a major problem, because initially in the antibacterial drug we learned that if you discontinue the drug, what happens? It becomes a so it is spreading rapidly, it is resistant, and because that till today, in fact that was a shame that India is going to be a developed country now, and still people are dying because of simple infections. We don't find any infections killing the patients in developed countries. Still, tuberculosis trend is still increasing. They always say that, all of you must have heard that MDR is in there, right? What is that? Multi-drug resistant and all drug resistant. In fact, the rate of cure is only 25%. You think? MDR and XDR. They are not able to completely cure the disease. On the top of that, one patient in lifetime affects 4 people on an average. How is that? One tuberculosis patient is affecting how many? 4. Because of the overcrowding. And त्या 4 मध्ये किती heal होता है? म्हणजे किती एकच heal होता. So indirectly, number of patients are what? Increasing, reducing. Constantly. And because of this is a major help. In fact, India spends a lot of money on tuberculosis because these drugs are given free of cost. On the top of that, the research, the drugs are very costly. XDR drugs are almost about 3,000 to 5,000 per month. Government cost. I'm not talking about MRP cost. And that too, so many patients are there. And that too, we are adding. So this is not only a national problem, not only the personal problem, family problem, social problem, but also the national problem. Because of that, these drugs need to be learned carefully and maybe studied carefully. And the infection also needs to be studied very carefully. So pulmonary TB is what is most common, right? And we have extra pulmonary apart from lungs. We also have the tuberculosis can be classified like we have primary TB and what is that? What is primary tuberculosis and secondary tuberculosis? We can. This is what is this classification you understood? Pulmonary and extra. What is primary and secondary? Primary tuberculosis and secondary tuberculosis. Happens in childhood and primary? See, when the infection comes up first, it will happen. Like for example, we must have heard about pulmonary TB and now some bone has got tuberculosis or pelvic organs has got tuberculosis or TB meningitis. So when the infection starts in the body, that is what is called primary. Like for example, we have pulmonary TB. Because the infection spreads through what? Inhalation, right? So most common primary TB will be pulmonary. From the lungs, it may spread to the other organs through blood circulation. That is what is a secondary. So by and large, most of the extrapulmonary is what? Secondary. Alright? Most of, I will not say, because it can also have extrapulmonary TB as a primary. How can bacilli go by inhalation to the other organs? Bacillus, for example, a bone tuberculosis can be primary. The implant that was used, steel wires and all those things, that is contaminated with tuberculosis. Inhalation that is inherently went into the bone through the implants. So that is what is also can be a primary. Primary to bone to implant. Can it be abdominal tuberculosis primary? Abdominal, that means bowels, organs. But this may not be inhaled, this must be ingested. This must be. Have you heard about that bovine tuberculosis? Okay? Bovine tuberculosis. Now this is a bovine. Bovine TB is through milk. The cattle who are infected with tuberculosis. When you consume the milk of those cattle, and now this milk is inhaled or ingested? Ingested. So it will be primary where? In the lungs or in bowels? Bovine tuberculosis spreading through cattle, and that is what is primary? What is the primary? So primary tuberculosis can be anywhere the infection is starting with the first. Because why we classify it like this? Because the treatment depends upon this. Whether it is primary or secondary, or whether it is pulmonary or extramarital. That is then, we haven't started with any drugs till now, but this classification is very important. So we have understood how exactly it spreads. We have understood how exactly it will be classified like pulmonary and extrapulmonary and primary and secondary. Let's come to the symptoms. What can be the symptoms of tuberculosis? What can be the symptoms of tuberculosis? All of us know क्या है pulmonary with the symptoms क्या है? Chronic cough. I'm not saying 1 day का cough. I'm saying for around 3 weeks. Only cough or what is that? With hemoptysis or with expectoration, without hemoptysis? With expectoration. It's a productive cough. I can see the productive. With what? Tubular is blood. Hemoptysis. With hemoptysis. Along with that, there is a low grade fever and a weight loss, significant weight loss. 10% of the body weight is lost in 3 weeks. A very short span of time, there is weight loss. That is what is also a peculiarity of tuberculosis. Peculiarity of tuberculosis. Very short span of time they have. So any patients coming to you with chronic productive cough, with hemoptysis, with weight loss, always go for investigation. This is what is the most common tuberculosis, the pulmonary tuberculosis. What investigation will you ask for? X-ray. So what happens? The tubercle bacilli always grows in the apex of the lung. Why apex? Because it likes oxygen. It is an aerobic organism and oxygen tension is high in the apex. So we always very commonly see a destruction of the lung called as a cavity of tuberculosis. Can be seen in apex. Along with that, we also have the lymph nodes which are enlarged. कुठले lymph nodes आता है? These are hilar lymph nodes. कुठले? Hilum म्हणजे lungs hilum असतं ना hand मध्ये. Where the bronchi are entering. Hilar lymph nodes are enlarged. But if the cavity is not there, does it mean that tuberculosis is not there? Cavity may there, may not be there. Lymphadenopathy also an X-ray not seen very clearly. So can you diagnose, confirm tuberculosis on an X-ray? In fact, if it is a tuberculosis happened in the childhood, still the cavity will be seen sometimes. Does that mean it is an active tuberculosis? It is an ill tuberculosis. So X-ray finding is not completely suggestive of tuberculosis. Active or passive, that also cannot be confirmed. So X-ray is not the diagnosis or investigation of drugs. What do we go for? Can we go for? CT scan, MRI scan. Is it possible for every cough with expectoration to go for CT scan, MRI? Is it cost effective? Along with that, the CT scan with the cavity is seen. Is it an active tuberculosis? Are we going to do for any tuberculosis which has happened in the childhood completely cured? So even if it is childhood tuberculosis, it is completely cured, still you see the cavity. So radiological investigation has got no meaning in diagnosis of tuberculosis, because it will also diagnose or see the tuberculosis which happened in the past. Because once there is a cavity, the destruction cavity will always remain. It may reduce in the size, but the cavity may be seen. So, X-ray, CT scan is not the investigation. What do we go for? We go for AFP, stands for acid fast bacillus. The investigation of choice is sputum for it. And we not only take one sputum, but we take 3 samples. We take 3 samples. And these samples, at least 2 to be positive. At least 2 should come positive. At least 2 should come positive. these two should, this sputum should be early morning sample. थोड़ा confusion है? काहीतरी गोंधळ, काहीतरी गडबड, काय झालं? So sputum for AP, 3 samples need to be taken, at least 2 should be positive. If the patient cannot spit it out, 5 वर्षाचा मुलगा आहे, तो चुकेल का? मला येणार. 5 वर्षाचा मुलगा आहे ना, not able to spit it out. Of course, adults can spit it out. So what do you do in case of children? What do you do? Children will swallow, right? So we take early morning stomach aspirate. That means stomach lavage. Put the right tube early in the morning and take the aspirate from the stomach. Put the right tube in the early morning and take the aspirate from the stomach. Why early morning only? Why not in afterwards? Afterwards because सगळं निघेल ना जेवण खाल्लेलं दूध प्यायला निघेल और मिल्क मिल्क आउट so it's an early morning stomach sample. Along with that, we also have an ESR increase. In fact, many times extremely elevated ESR, highly elevated ESR is one of the diagnosis. X-ray is not the diagnostic. In USA, UK, the tuberculosis antigen test is very important. All of us, when we learn the other infections, like for example typhoid, malaria, dengue, remember that in the first lecture of infection, we learned about something about an antigen. What is that? Antigen is something of the microorganism which can be diagnosed in a pathological laboratory or which initiates the antibody production. So we can also, tuberculosis is also a bacteria, also has got an antigen. But I am saying that this is valid only in developed countries. Why not in India? If you do it in India, all become positive. Because every one of us is contaminated with tuberculosis. Every one of us, including me, has got tubercular bacilli in the lungs. Because we are living in India. That is what is the natural immune response. It is just waiting for your immune system to go down and the tuberculosis will come out. Whenever there is an HIV, which is the first infection comes up? Tuberculosis. Whenever your immune system goes down, those who are having very stressful life, you must have heard about what is happening in the Sion hospital. Those who are 24 hours duty, 36 hours duty, malnourished. I think 3 years before, in the hostel of the Sion hospital, suddenly there are 4 to 5 people, students became positive tuberculosis. Because, and they say because of the stressful life, they are working in a very bad situations. The diet is not that good. TB is also called, what is that? Poor man's disease, right? Kushtarog. No, what is Kshay-rog? Kshay-rog, right? What is Kshay-rog? It is always a poor man's disease. Those whose diet is not that good, those immune system is not that good. So if you do it in India, every sample will come positive. Does that mean people are having tuberculosis? Because it's an antigen test, will come positive in fact with a very small amount of tuberculosis. And also, when you send a sample, for example, sputum they have sent, when it comes outside, the bacilli which are there can also sit on the sputum, right? That means rate of contamination is also very high. And because of that, the antigen test is not done in India. Because everyone becomes positive. There is not a false positive. What is false positive means? False positive means report is positive, but it is false. That means disease is not there. So in this case, tuberculosis antigen test is not, except few conditions, like for example, genital tuberculosis. You can make them. Only in case of genital tuberculosis, they do the tuberculosis antigen test. Otherwise, not done. So gravitating down, we can finalize about sputum for AP is the investigation of choice. For pulmonary TB I am talking about. What about extrapulmonary TB? Do they also have cough and all those things? This is also cough. Bone tuberculosis. What are the symptoms? You must have heard about that. Quad spine. Yeah. Spine tuberculosis, very common. You can also have liver tuberculosis, ascites because of tuberculosis. So extrapulmonary से काय symptoms मिलते हैं? Will they also have cough? They will not be there. There are no traces. Only low-grade fever and weight loss. And with some localizing sign. For example, if it is a bone tuberculosis, you can have bone pains. Or you can have, for example, very commonly they have spine tuberculosis. The vertebrae just are collapsed because of tuberculosis. Otherwise, the nerve that is coming out will be compressed, right? So you will have neurological symptoms. So wherever it is there, you can have some local symptom of it. But otherwise, the symptoms per se are not very alarming. Many a times, there is some problem. We don't know what is happening. Weight loss is there, low blood fever is there, blood tests are normal, antibiotic is there, tag reported nahi. We go for an ultrasound and we find out that the liver has got some cavity. When they aspirate, they find the tubercle bacilli. Many times, because symptoms are not very peculiar about this. So when somebody has got low grade fever, along with weight loss, with history of tuberculosis in the past, can happen like secondary ki primary effect. Extrapulmonary will be more commonly what? Secondary ki primary? Secondary, right? So he may have history of tuberculosis in the past. So wherever you get patient about having weight loss, low grade fever, with history of tuberculosis in the past, think about tuberculosis. Will you go for sputum in this case? Will you go for X-ray in this case? What will you do? Wherever patient has got localizing sign, for example, bone has got localizing sign. So take the sample from that particular area and examine for AF. Sputum card as well, sputum is a sample taken, right? So whichever organ that has got tuberculosis, take the sample. If it is an abdominal tuberculosis, take the fluid from the abdomen. Ascitic tapping it is called. So wherever there is an infection, take the sample and send for acid-fast bacillus. Acid-fast.
X-ray when done with bone tuberculosis.
Yes, it depends upon where exactly. If you can finalize the spine, because what will you find? Anywhere there is a tuberculosis, you can see the destructive lesion. Many times, this is called the femur, and you can have tuberculosis of the femur, and you can have this destructive lesion. One patient has got chronic hip pain, or because of the destructive lesion, there can also be fracture, common fractures. What do they call that? They call it pathological fractures. म्हणजे एक जिना उतरला आणि फ्रॅक्चर झाला. इज इट नॉर्मल? Normally वरून पडलं तर फ्रॅक्चर होणार, right? Not एक जिना. But if the bone has got lytic lesion like this, the patient can have a very common fracture with a trivial injury also. So then you can find out that okay, the X-ray is being taken and there is a lytic lesion here, and this is a tuberculosis. So depending upon where exactly you are finding the localizing signs. In case of chronic tingling numbness here, maybe there is some swelling in the vertebral area, you can go for X-ray of the spine, EP lateral. You can see the lytic lesion. What you find is a lytic lesion. Bone destructive lesion. Wherever you have a bone tuberculosis. Even if it is liver tuberculosis, you can find an abscess cavity. Tuberculous abscess cavity. So diagnosis sometimes is very difficult in case of extrapulmonary, because you may not have very alarming signs. So in the treatment of tuberculosis, we have one category where you are confused. You start that category and give it treatment. So by and large, what you have learned till now is tuberculosis is pulmonary, extrapulmonary, symptoms, primary, secondary, investigation of choice. You can go for sputum for AP. You may go for an X-ray test to know where exactly it is, in which lobe it is. You can go for the other test and then you start the treatment. Now once you confirm the tuberculosis, you can start the treatment. Of course we have certain drugs, but the problem is how frequently, which drugs, what will you do in case of the resistance and all this. Because tuberculosis is a common infection, people going for resistance. drugs, we have a primary drug or first line of drugs and a second line of drugs. First line and second line of drugs. So what are the first line of drugs? First line of drugs are 5. H, R, Z, H stands for ionization, reformation, pyrazanamide, ethambutol, and streptomycin. Ionized, reformation, pyrazanamide, ethambutol. Doses are also very important to be learned. Milligram per kg per day or per dose. All in milligram per kg. All these drugs are milligram per kg per day. 5, 10, okay? Rifampicin is 10. Pyrazanamide is 25. 15. Ethambutol. And lastly is streptomycin. Lastly is streptomycin. We also have second line of drugs, like for example we have rifabutin, para-amino salicylic acid. Full of this thing. Amic acid. So nowadays they have included the amox with clavulanic acid also. And the drugs are getting added more and more. I think recently there was a good invention that some drug is added and that is under trial these days for the resistant tuberculosis. Now first line of drugs are the most effective drugs, are most powerful drugs. So, and second line of drugs are additional, optional, but not very common. Which one will you use first? First line, second line.
First line.
Right? In Parkinsonism, we use the least powerful first. Here, most potent first or least potent first. Do we continue the tuberculosis treatment for lifetime? No, right? Only 6 months or any specific duration, right? What is the primary goal of our treatment? To kill all bacilli. So I will use these drugs first. The problem is we require a very long course for 6 months minimum, because the bacilli are hidden from the drugs, because there are intracellular bacilli. Cell च्या आतमध्ये extracellular bacilli can be easily killed, but intracellular bacilli is not easy to get killed. About 90% bacilli can be killed within 3 weeks of treatment. 3 weeks. 90% bacilli can be killed. So the problem is patient becomes asymptomatic within first 2 weeks of treatment. Because cough reduces, appetite improves, fever goes on. Usually patient thinks that okay, I am cured now and stops the treatment. And that is what is the major problem for resistant tuberculosis. So what they have done? Shots. Now of course these drugs are being given by Government of India free of cost. So they wanted the patient to take the drug for all 6 months. So what they have done, they call the patient to the health center and ask the patient to take the drug in front of the medical person who is there in the hospital. That means patient has to all the way come from Varli Kolivada to Prabhadri center, take the drug, घेतलं, जा. Is it patient friendly? Patient says, I have my job, I have to come down here, then I miss 2 buses and I go to. So what they have, so DOTS was a very good program. Direct, what is that called? DOTS, directly observed therapy. But the problem was patient's compliance or patient's participation in that. So what they included the private practitioner also into it. That is, whoever is a general practitioner nearby will be given a card and the patient consumes the drug in front of that Bajuwala GP and the GP will maintain the card and send it to the health center at the end of the month. So this was a DOTS Plus program. DOTS Plus, that means additional features, that is incorporation of the private practitioners into it. The only idea is to take the drug completely. Patient doesn't take the drug completely, goes into resistance, and because of that we are finding so many patients who are becoming resistant of tuberculosis. So we have these drugs, but when are you going to give which drug for how much duration? That is what is called as categories of tuberculosis, or maybe called as a program of tuberculosis. Drugs are like about 10-12 drugs. Most of the drugs are protein synthesis inhibitors. I am not going to the mechanism of all the drugs separately. Doesn't make much difference. So what we need to understand is which patient, which drug, for how much duration. That is what is another most important thing, practical thing we want to learn. So we have 3 categories of tuberculosis. Category 1, Category 2, and Category 3. Category 1, Category 2 and 3. I am going to use the same drugs, these drugs, through these categories. What is Category 1? It is a new pulmonary TB. A new patient who has never received any AKT. AKT stands for anti-Stokes treatment. Or a new patient with extrapulmonary. The lesion size more than 5 centimeters. Lesion is more than 5 centimeters. Lesion is more than 5 centimeters. So new pulmonary TB, a new extrapulmonary TB, lesion size more than 5 centimeters. If this is a patient, I am going to give treatment for 6 months. In the 6 months also, we have 2 months and 4 months. In every of these categories, again we are going to have 2 phases. One is called as, what is it called as? Intensive phase. The first phase is called intensive phase. And a continuation phase. Intensive as well as continuation. In the intensive phase, I am going to give 4 drugs. The formula is like this: 2HRZE plus 4. For 2 months, I am going to give 4 drugs, HRZE, and 4 months 2 drugs, So I am going to give 2 HRZE plus, that means for 2 months I am going to give 4 drugs, and next 4 months I am going to give. So for all new patients, I am going to have category 1. What I am going to do at the end of this 6 months, again investigate the patient. That means again do sputum for ALP or again do biopsy from the lesion, whether it is positive or negative. So at the end of the therapy, we always do the repeat test, repeat investigation, and then only we can declare that the patient is cured. Then only we will declare that patient is cured. Because possibility is not all bacilli are killed. Because if the patient still has got bacilli, that means patient is going into what? Resistance. Ideally, at the end of the 6 months, patient need to be completely free from all bacilli. That means sputum for AB should come negative, or the lesion ka biopsy should come negative. Category 2 is for special patients who are having relapses or failures or those who are defaulters. All they are special patients. All three are special. For example, what are the relapses? Relapses. Patient had tuberculosis, patient was declared cured and again become positive. Relapses. What is failures? The treatment failed early. See, understand what happens in the 6 months. Within 3 weeks, patient becomes asymptomatic. 90% bacilli are killed in first 3 weeks. If the patient has started the treatment, but patient has not become asymptomatic at the end of 3 weeks, what does that mean? Treatment is then you have to shift to the category 2. Because what does that mean? For example, patient has relapses. What does that mean? Once more, that means must have been resistant, right? In failures, patient is not responding to the regular drugs. What does that mean? Or defaulters. Defaulters, those who have started the treatment but stopped it for more than 3 weeks, called as defaulters. Because category 2 is a special category for those who are on a risk of going into resistance. Category 2 is a category in which patient has got more risk of going into resistance. For this we require 8 months treatment. We require 8 months total therapy. And the formula for this is like this: 2HRZES, all drugs, 1HRZE, just 5. 2HRZES, 1HRZE. If you remember, streptomycin is which category? Aminoglycosides. The most toxic drug. Remember the renal toxicity and ear toxicity. So we are not giving for more than 2 months. Maximum 2 months. Then 1 HRZE and then 5. So new cases are covered, extrapulmonary large lesions are covered, special patients are also covered. Then we go for category 3. Now category 3 are for those patients who are, when your diagnosis is doubtful. Diagnosis is doubtful. Many times patient gets some ulcer on the skin. You are giving antibiotics, you are taking the culture, you are doing all treatment but it is not responding. Tuberculosis, the problem is also if you do culture. What is culture? Because we grow the bacteria into the laboratory. Tuberculosis is a very slow growing bacilli. It is also not cultured that easily. The diagnosis is also difficult. It was a very slow growing organism. So even culture becomes sterile. Culture becomes, no culture is found in case of tuberculosis. Again, added problem in the diagnosis of tuberculosis. So if you are finding some lesion, which is not responding to any other antibiotics, is also sterile, only culture. The patient has got ESR raised. Many times patient comes with arthritis, means joint swelling. What we think most common cause? Osteoarthritis. So we try to give treatment, but osteoarthritis also patient not responding. Other common causes in gout, but uric acid is also normal. Third common cause is cause of Amavad, rheumatoid arthritis. That is also negative. So three most common causes are ESR is raised. Think about tuberculosis of the joint in that particular. So many times we are not able to arrive at the definitive diagnosis. The diagnosis is what is doubtful. And we will go for category 3. Category 3 for doubtful patients or doubtful cases. Treatment is again for 6 months, 2 HRZ plus 4 HR. 2 HRZ plus 4 HR. HRZ plus 4 in this particular. Again the problem comes, for example, you have started even category 3, but that also is not responding. That means patient is not becoming symptom free. Now what will you do? That means patient is either going for resistance. Now what are the types of resistance? Because this is what is going to be more important cases. We have a mono drug resistance, multi drug resistance, and XDR. Mono drug, multi drug, and all drugs or XDRs. Mono drugs का अर्थ असा है either most common drugs or important drugs are H and R, either H resistance or R resistance. That means INH stands for isoniazid. H चा resistance किंवा R म्हणजे कुठला? Reformation. Either it is INH resistance or reformation resistance. For example, mono drug resistance. आता याच्यामध्ये कुठले ट्रीटमेंट देणार? Better to do शकणार नाही, right? So what will go for? If the H is resistant, give RZE for 12 months. RZE for, if R resistant, you can go for H plus Z plus add rifabutin. The here protocol is constantly changing. You get a fresh protocols, but if the R is resistant, you can go for HZ plus rifabutin for again 12 months. Now protocols for these and these are constantly changing. They say whichever drug that is sensitive, give it for 12 months. How do you know the patient is resistant to drugs? Send the sputum for culture sensitivity. Report comes after 10 days. Because it is very slow to culture as well as to diagnose properly. So you can go for culture sensitivity. In that they use all drugs of tuberculosis till now. And you know how do they do culture sensitivity? There is a plate like this. The प्रत्येक plate मध्ये we have an antibiotic. कुठलं तरी एक. And they culture this plate. ज्या these are called wells. ज्या well मध्ये बॅक्टेरिया ग्रो झाला नाही याचा अर्थ that antibiotic is sensitive or working. जिथं ग्रो झाला याचा अर्थ that is resistant. So, if it is a mono drug or multi drug, they give treatment according to which antibiotics are sensitive. Give it for 12 months. Give it for next 12 months. There is monodrug, multidrug as well as monodrug, multidrug and XDR center. Is there any role of surgery in this case? Will you go for surgery for tuberculosis?
Surgical
Then you completely remove the lung. Pneumonectomies. They remove that because it is not very easy, and also the patient is going to spread to the others. So they do removal of that part of the lung, or they can completely remove one side of the lung, whichever wherever is the lesion. Pneumonectomies are commonly done. It is done today in Shivdi TB hospital. The biggest TB hospital in Mumbai is Shivdi TB hospital. Special, and people are afraid to work over there. Shivdi line. And people, why? Because all over India resistant cases are there, coming there for the treatment. Of course, it's all government sponsored hospital, because it's a government program to reduce the burden of tuberculosis. If the patient is pregnant and tuberculosis, what will you do? Are the drugs safe in pregnancy? Except streptomycin, all the others are safe. First line I'm talking about. Second lines are not that safe. But first line, except streptomycin, other drugs can be given. Other drugs can be given. You also remember one side effect of all drugs, because commonly you come across when you start a treatment, the patient has got these side effects. For example, rifampicin has got red urine or orange color urine. When the patient is taking rifampicin, has got an orange color urine or red urine. You don't say that it's from hematuria, red color urine. Ethambutol, neuritis. Patient may complain about, because these are not drugs that are going to give for only 5 days. कितने महीने आप बताते हैं? 6 महीने, 7 महीने. So also important to know the side effects. Ethambutol is the most common is optic neuritis. Optic neuritis. Pyrazinamide. Hepatitis. Patient may have jaundice or clinically increase in the bilirubin. INH is also neuritis. Streptomycin, deafness, and vertigo, and renal. One word side effect that you should remember for these drugs. चला चला बाकी मी काय घेत नाही आलो. We have one more same drugs. Few of them I'm going to use for leprosy, but it's not that common. We're going to cover on Wednesday section. Wednesday